What are the most common allergens that you typically see, especially as it relates to kids? When do you know whether something is truly an allergic reaction or not?
Because when you really think about it, this is why food allergies are often kind of strange and hard to understand.
Dr. Zachary Rubin is a pediatrician, allergist, and immunologist who works closely with children and families dealing with allergies.
Through his clinical work and public education, he helps break down what allergies actually are.
Normally, we think of food as something that sustains life, but why is it that some people, they look at food and their immune system thinks, oh my gosh, this is a germ, and it could actually end somebody's life? Now, when it comes to food, I'm diagnosing food allergies almost every day in my clinic. So the problem is that food allergy is a chronic disease, and you either really have it or you don't. And the current evidence suggests that avoidance is not helpful, but we don't know how much food you need to consume.
Hi, and welcome to our next episode of Kidsy Connects. I am so pleased to introduce to you our next guest, Dr. Zachary Rubin. He is a double board certified pediatrician, an allergist, and immunologist who practices at Oakbrook Allergies in the Chicagoland area. He's a nationally recognized medical educator and public health advocate and shares evidence-based and accessible advice on everything relating to allergies, asthma, vaccines, with over 4 million followers. Dr. Rubin, welcome to Kidsy Connects. Such a pleasure to have you on today.
Thank you so much for having me.
I have a lot to uncover with you because this is such a dense and hot button issue. And I think it's also a space that a lot of parents have very little knowledge in. So let's do some myth busting, some, fact checking today, if that's okay with you.
Absolutely, it'd be my pleasure.
Okay, let's start off by asking, what are the most common allergens that you typically see, especially as it relates to kids?
Absolutely. So I see a lot of kids, whether it's for food allergies or for hay fever, also known as seasonal allergies or allergic rhinitis. So if we're talking about the environmental allergies, the most common ones in the Chicagoland area that I see would be dust mite as the indoor allergen. If they have pets, that's pretty common as well. But tree pollen can be quite nasty here in the springtime, as well as ragweed. Now, when it comes to food, I'm diagnosing food allergies almost every day in my clinic. Most commonly, it's either peanut or eggs. Those are the top two, and that is closely in line with what we see with the national statistics.
Interesting. And when you say you're diagnosing these allergies, are you seeing, I guess on a scale of 1 to 10, like how severe is the reaction to these allergies?
Yeah, so the problem is that food allergy is a chronic disease, and you either really have it or you don't. And then it's the reactions that you're treating could be mild or severe. And unfortunately, the type of testing that we do cannot reliably predict if someone's going to have a severe life-threatening reaction or if it's going to always be a mild irritation. And the challenge becomes when you have a family coming in and they have a baby with a mild rash. Is that truly an allergic reaction? Or is this like a contact irritation, which a lot of babies have sensitive skin. So anything that's put on their skin could cause redness. And if they're not bothered by it, it's not likely an allergy. We have to differentiate that between redness on the skin and hives that look like mosquito bites. And especially if the child is under distress of any sort and you have to treat it, then that's concerning for a potential food allergy, which we test for in the clinic.
I want to double click into that because, as we know, the skin test is one of the sort of the quickest and easiest form of testings that a lot of parents subscribe to when trying to diagnose whether their child is allergic to something or not. From personal experience, I will share with you that when my daughters were 10 months old, both of them, when they were given egg for breakfast, broke out into a sort of redness and maybe tiny, tiny baby bumps on their skin. They were breathing fine. They were behaving fine. And so what I did, and correct me if, this was the right or wrong way to do it, was I just continued to give them egg every week in small doses. And then after a month or two, there was no reaction, which I think brings me to my point is, when do you know whether something is truly an allergic reaction or not?
Right, because in your situation, it's not clear if that was really truly an allergic reaction or, again, just a mild irritation. Without seeing it, I can't say with 100% certainty, but we take the history, the story of which the child experienced, and combine that with testing to approximate a diagnosis. The gold standard is actually saying, hey, come into my clinic for a few hours and we're going to try it in here. We call it an oral food challenge. And so that's where we can really verify what's going on. But the telltale signs of an allergic reaction to food that is potentially concerning would be hives. So that's going to be these discrete bumps that are usually pretty large and very itchy. You could get swelling, especially around the lips or eyelids, but it can happen in most parts of your body. It could be severe vomiting that can occur. And with baked egg, it could actually be a little bit delayed, but it's usually pretty early on, within a few minutes to an hour or so. You could also have wheezing, coughing, difficulty breathing. You could have a combination of those symptoms, and you could also have a drop in the blood pressure, which can cause passing out, or the skin turns pale and blue, and that's anaphylactic shock. That's when blood is pooling out of the vital organs, and that's very scary. Now, most of the time for babies, you're never going to see that, and I'm knocking on wood right now because I've never seen that in a baby, but I imagine that would be really, really concerning. And so let's say you have this happening multiple times. That really helps hone in on that diagnosis. And then you would come into the clinic and an allergist would do usually a skin test where we take an extract of that food, let's say an egg extract. We scratch the skin to place that little bit of egg protein right under the top layer of the skin. And if you have cells of the immune system that have these proteins called IgE, which is short for immunoglobulin E, that's a specific protein tag or antibody that could bind to the food, that leads to histamine release, and that causes these surface blood vessels to leak out and create a little hive. So having the history plus the skin testing being positive is the safest way to approximate a diagnosis of food allergy. What we run into as a significant challenge is you could have a story like what you said, where there's a very mild rash. It doesn't sound like a true allergy. And then you test not only for egg, but a bunch of other foods, and things pop up positive. That could be falsely positive. There's a high false positive rate among skin testing for food allergies if you do not have a clinical history of a reaction. So it's a very important nuance that people need to understand, which is why allergists like myself are moving away from doing panel testing to look into food allergies.
I love that, because I think what I'm also hearing you say is that perhaps there is a false positive that can arise in those situations. Would that be fair to say?
Absolutely. There can be false positives. Also, it could tell you there's a potential that something can happen in the future, but maybe not now. And we know now that if we delay the introduction of highly allergenic foods, we do increase the risk of the child developing a food allergy. That is a paradigm shift from what the American Academy of Pediatrics recommended back in 2000. But that recommendation of delaying the introduction was meant for high-risk babies, not for all babies. And as we got more science, the evidence changed and our recommendations change. And that's how the scientific method works. You try to come to the reasonable best conclusion with what evidence you have. And then when you get new data, you change that opinion and change the management strategies. And while it's starting to show signs that peanut allergy is going down because of it, it's not the only reason why we're seeing an explosion of food allergy diagnoses. There's many more reasons, which I'm sure we'll get into, as to why that may be the case.
Okay, I have so many questions. And to your point, and I'm going to try to get into all of it, what you just said is actually something I also did with my two girls, which was very early on before they turned 1. Every week I introduced a new nut butter to them. So it was peanut butter, and then kind of waited a few days, made sure everything was okay. Then cashew butter, then almond butter, then sesame or tahini, an egg, and sort of all the allergens that you're talking about. I tried to make sure that they were getting exposed to it. Is that a good strategy for parents to adopt? Because you talk about introducing the allergens early. And so would that be, say, a method that people could start deploying?
Right. And it's not only just early, but it's often. So once it's introduced into the diet, you need to make sure it's in the diet, maintained regularly. at least 2 days a week as an example, because oftentimes we will have families where they said, oh, we tried peanut butter at 6 months and they did fine, and then they don't touch it for a couple years. So that initial exposure has to be reinforced to help the immune system understand that this is truly not that big of a deal. Because when you really think about it, this is why food allergies are often kind of strange and hard to understand. Normally, we think of food as something that sustains life. But why is it that some people, they look at food and their immune system thinks, oh my gosh, this is a germ, and it could actually end somebody's life? That's a very unusual circumstance. And we think back that from an evolutionary standpoint and a survival standpoint, that some foods would spoil. Some foods would have toxins in the environment. And so some people would evolve to have this kind of response to protect the body from these types of pathogens, these germs that could develop on spoiled food or toxins. And so it's likely an exaggerated response born out of that.
I love that, because you're right. Like, so much of it is evolutionary and protective. I think a lot of parents, when they are navigating food, and looking at food as a potential source of or cause of allergies, there's so much fear, because everybody, I think, in their heart of hearts, wants to raise a child that is not allergic to XYZ. It just makes life so much more complicated and difficult. And then you have to make sure they're in a nut-free classroom or nut-free school, or even airplanes now have adopted nut-free for travel. Is there something people can do to avoid that? Or are there just situations where it is inevitable, it's genetic, it's part of the DNA makeup, there's nothing you can do?
Right. So that's a really important question that we're still trying to grasp, and we're researching actively. What is the underlying reason why food allergies are becoming more common? What is the cause of it, is what we're getting at here. And so one thing we mentioned earlier is that earlier introduction may reduce that risk. It's not entirely 100% effective, but it is definitely helpful. A lot of parents ask, what do I do during pregnancy? Do I avoid the foods that are highly allergenic, like peanuts, or do I consume them regularly? And the current evidence suggests that avoidance is not helpful, but we don't know how much food you need to consume, frequency, quantity, any of that during pregnancy to really know how much we should be recommending. We just don't know. But avoidance, we know, is not necessarily helpful. So there's that. Now, there's a lot of other potential risk factors, and I'm gonna say they're risk factors and there's associations, but they're not necessarily causative. And so one of the hot button topics right now is the human gut microbiome. That is the trillions of bacteria that live in the gut that also live on the skin, and they're different, and they live amongst us. They often help with digestion, and they may present some of the food proteins to the immune system. And there's good bacteria and there's bad bacteria. And so alterations in that environment in your gut may lead to an increased risk of developing a food allergy. And how can we have what we call dysbiosis, where there's an abnormal milieu of bacteria? How does that occur? Well, some examples include C-sections. If a baby is not born through the birth canal, they're not getting exposed to the vaginal bacterial flora that could colonize the intestines, right? So there is some evidence to suggest an association between increased C-section rates and increased development of diseases like food allergies. Early antibiotic use is the same kind of concept. You're killing bad bacteria, but also good bacteria as well, and that can change the gut microbiome. There's also antacids used to treat reflux that could alter the gut microbiome as well. And then to some other potential risk factors, we look at vitamin D levels, and low vitamin D is associated with developing food allergies. Again, these are risk factors, they're associations, they're not causative. And with a complex disease like food allergies being a chronic disease that has a genetic component to it, there are environmental risk factors, but there's no one particular intervention that's going to completely prevent this from happening at this time that we know of.
That's fascinating. Is there a Are there any drugs or medicines in the market that can help perhaps reduce the reaction of a food allergy? And I ask that question because, we talk about environmental allergies, and so many parents, when their child is of a certain age, will say, well, if I give my kid an antihistamine, they're able to go and play on the soccer field for 2 hours and tolerate the environmental allergens. Is there something similar within the food group?
Yes. So there's two different interventions right now. One is something called OIT, which stands for oral immunotherapy. So that concept is taking small but incremental doses of what you're allergic to, kind of similar to how allergy shots work, but you're taking it by mouth. And that can create a level of desensitization, meaning the immune system can tolerate a little bit. Like if you have an accidental bite, it could significantly improve your chances of doing fine. It's not 100% effective. There are side effects associated with it, but for certain families, it could be very helpful. So talking with an allergist who specializes in OIT, they could really help families. I don't think it's necessarily for everybody, but there are families that could do very well with it. The other option that's FDA approved as a medication is something called omalizumab, which that's the generic name for Xolair. So that's an injectable medicine that's been approved since 2003 for severe asthma. It's been around a while. It's an older drug that's being repurposed to treat food allergies. It was a little over a year ago was FDA approved to treat food allergy. And it doesn't matter what food you're allergic to. If you have evidence of the IgE antibody that's specifically binding to that food, you could do this therapy. And it's an injection that's given every 2 to 4 weeks based on a couple of parameters, including their body weight and the total IgE antibody concentration in their blood. And so you may get one injection once a month, or it could be as much as 2 injections every 2 weeks, but it binds to those antibodies that we mentioned to help reduce the immune system activating to create a severe reaction. And it is something that, especially if somebody has multiple food allergies, may be an option to consider.
In your experience, are you starting to see perhaps more sensitivity today in terms of food allergies versus a decade or 2 decades ago? Like, is it starting to become more prevalent?
Absolutely. So just from a personal standpoint, I had a milk allergy that I outgrew pretty early in life, and I knew one girl with a peanut allergy, and now I'm diagnosing it practically every day. This is real. It's a real phenomenon that we've seen this explosion in the number of cases, relatively speaking. It's more than tripled in the last 20 years.
Wow.
Of how common it is. We're at the point where approximately 10% of the population has a food allergy. That is
wow.
And from a pediatric standpoint, it's about 2 kids per classroom. So that is a significant public health problem, especially because a lot of people have very little knowledge about what food allergies entail, and that creates a lot of confusion and unfortunately a lot of resentment, because some of the policies that are in place to help protect people, they're an inconvenience to many families. I can empathize for families who are told you can't bring in peanut butter for your child for school, and that may be one of their favorite foods, but they can't because they're trying to keep other kids safe. And so we have to really do a concerted effort to have a better understanding, providing education and advocacy for those who are living with food allergies, and help people who don't understand why are we doing these different interventions. And I'm not here to say that having a peanut-free classroom is the one way to do it. It's certainly not. But the policies that are put in place are there for a reason, and that reason needs to be communicated clearly and effectively so that people can come from a better sense of understanding.
Yeah, I definitely experience that pain point on a daily basis because my girls' school here in Chicago, it is a nut-free school. And you cannot bring any snacks that have any sort of nuts on them. And then they even go as far as, like, if you're bringing in treats for the classroom, it has to come from a nut-free facility or have a nut-free label on it, which is not so easy to find, and also quite, cumbersome, it's expensive, and it's a whole song and dance. But to your point, I think because there's such a lack of education in this space, and a lot of fear mongering as well that goes on. If you were designing a classroom, like a hypothetical classroom, what sort of policies would you implement that would protect those that had the allergies, but also not be so punitive to the 80% of the group that didn't have an allergy?
Right. So we have to find a way to balance this. So one of the approaches, which I do believe in, is for lunch, as an example. There should be a table available for families who want it that is allergy free. That specific spot where you can clean the surfaces well, and the kids who sit there all have an understanding about food allergies. You know, you don't want to ostracize children because of their disability, because food allergy is a disability. So they should have a buddy or two to sit with there and make sure that they don't feel alone and ostracized. Because children living with food allergies, as well as their parents, are at higher risk of being bullied. They're at higher risk of developing anxiety and depression. And so we want to make sure that we are mindful of that and making sure that it's as acceptable as possible. So having that one table where we can control that area and also invite kids who can be good friends and advocates to that will be very helpful. I personally feel that if a school is completely policy nut free, you run into a false sense of security. And there is evidence to suggest that schools that are peanut free have higher rates of epinephrine use, because the families that are told that it's going to be free can't guarantee that one kid makes a mistake. So the hybrid approach of saying, all right, the classroom itself, if you're going to serve snacks, should be nut free. That way the teachers are not as concerned about making sure that every single surface that the child eats at is safe. And children move around quite a bit and they could share things. So that's why it makes sense in the classroom for a snack time, but at lunch or mealtime, that should be a specific area that is cleaned. And it's not to say that I'm absolutely right, because we're still learning this. And I always go by what is the evidence. So I want to make sure that's clear for people, that my personal opinion is driven by evidence, but I understand too that the evidence evolves and we still need more information about food labeling, right? So one of the questions that people ask is, yeah, the label says contains peanut. I know I shouldn't have that. But what if it says may contains, or processed in a facility, or contains potentially trace amounts? These are precautionary labels that don't mean much clinically. They're legal terms, and it's hard to discern what that actually means. And there's ongoing efforts to try to clarify that, because once we do, food safety will be optimized and we'll be able to expand people's diets for everybody, essentially.
You talked about earlier about there being a lot of data and evidence around, the gut, the microbiome, a vaginal birth versus a C-section. Is there any evidence to suggest that there are children who develop a food allergy or much later in life, but were absolutely fine consuming a certain food, say from 0 to 5, and then all of a sudden they turn 6 and they're having this adverse reaction? Like what's the story there? Does that happen?
That happens, unfortunately, a lot more common than you think, especially for adults. So of the adults living with food allergies, about half of them develop food allergies as an adult. And so you can theoretically develop a food allergy at any point. Why that's the case is very complicated, and we don't know all the answers to it, but I'll give the classic example. So one of the most common food allergens in adults in the United States is to shellfish. And so one of the reasons why that may be the case is as you're growing up, you develop a dust mite allergy. That's a common indoor house allergen, right? It's in any upholstered furniture, in your bedding, sheets, carpet, etc. So wherever there's human skin cells, there's dust mites. And from a biological perspective, there are a lot of similarities in the protein structures of dust mites to shrimp. So if you become allergic to dust mites, you are at higher risk of developing that shrimp allergy. And it unfortunately becomes usually lifelong for most people who develop that as an adult. Why this happens for kids who are 6, 7, 8 years old is really unclear at this time. But as you mentioned, the most of the time, food allergies are diagnosed before the age of 5.
Yeah, that's fascinating. Especially to, one day wake up all of a sudden and then find yourself having an adverse reaction to something. I have so many questions. I'm trying to get to the ones that are most relevant. What is the relationship between eczema, asthma, and allergies? And are those three all somehow interconnected?
Absolutely. We often refer to that actually as the atopic or allergic march that starts with atopic dermatitis or eczema. And so the best way I try to explain it to people, and again, all of our understanding is changing and evolving. So what I say now may not be as relevant in 2 to 5 years. So I just want to make that very clear because we're learning a ton. It's even different from when I started medical school, so eczema is a skin disease that is characterized by itching, scratching, redness, swelling, and you typically get it in different places as a baby compared to as a child and an adult. So that it moves around a bit. It's often referred to as an allergic skin disease because it is the immune system abnormally responding to the outside world. So that's why it's often lumped in the allergic skin category. But it's multifactorial. So one of the places this starts is that there's a disruption of the skin barrier, and that's often from genetics. So if mom or dad have eczema, the child has a higher chance of developing it as they pass down genes like FLG, which encodes for a protein called filaggrin. That helps anchor the skin together, and if that's mutated, you're at higher risk of water being lost from the skin dries out, you get itching and you scratch. And when you scratch, you get more inflammation. The immune system comes in and creates the rash, which creates more itching, which compels you to scratch. So we call it the itch-scratch cycle. That also can be set off by various allergens in the environment, like pollen, dust mites, or you could also have peanut butter on your skin, and that can create further inflammation in a subtype called Th2 for short. So when that happens, allergy antibodies are produced, those IgE antibodies, and they can circulate throughout the body and lead to asthma, allergic rhinitis or hay fever, food allergies. So that's how eczema can kind of march its way towards these other conditions where many folks have 2 or more of these issues after they started having eczema as a child.
Interesting. I want to switch gears and talk a little bit about medication. I think we are all very familiar with good old Benadryl, and that every household should keep Benadryl in their medicine cabinet. Is that, what is the efficacy of Benadryl? When should parents use it? Is that the go-to to helping, treat, I think, a mild allergic reaction? What is your opinion? And what are some of the other medicines on top of that every household should keep in their medicine cabinet?
Right. So we are now moving away from using diphenhydramine, also known as Benadryl, for most situations. The reason being is that when you look at the totality of the current evidence weighing the risks and benefits of this medication, Benadryl was discovered in the 1940s. And for many years, these drugs were not regulated. And then we started getting more regulations in the 60s and 70s that many over-the-counter medications that you take were grandfathered in and not given the same level of scrutiny. And so as we start to really study this more, we're understanding that if you're using Benadryl to treat an allergic reaction and you think this is going to be a superior medicine, the onset of action of Benadryl compared to Zyrtec, also known as cetirizine, is not much different. There's not really a clinically significant difference where you look at the effectiveness or the onset of action, like how fast it takes for it to work. They're pretty similar. The side effect profile is what gets a lot of folks like myself concerned, because if people are taking this chronically, especially, it's a medication that readily gets into the brain. It can make you tired, sleepy. 10 to 15% actually have an opposite effect. We call it paradoxical excitation. It's where you get actually aggressive and anxious and have a high energy. And we see this with kids from time to time where they're literally like bouncing around the walls, essentially. So you have that. You also, especially for older people, can have anticholinergic effects, meaning the neurotransmitter acetylcholine is blocked, and that causes a dry mouth, blurry vision, urinary retention, constipation. And if you're taking this chronically, there are now studies that suggest an association between chronic Benadryl use or other anticholinergic medications and developing dementia later in life. It's not to say that Benadryl causes it, but try to warn people against that, because some people use Benadryl as a sleep aid. It really should. Now, every so often using Benadryl, not a big deal. No one's going to really be too concerned about it. But if you're looking at having a safer alternative that's just as effective, having Zyrtec on hand, a second-generation antihistamine that's less likely to cause those side effects, makes sense to do something like that. There's other alternatives like Claritin or loratadine, Allegra, fexofenadine, Xyzal, levothyroxine. So it's not just Zyrtec, but it's one of those newer antihistamines may be totally appropriate for that. The only reason I see most people needing Benadryl is if they need it in an IV form, where you can't take something by mouth, and the only antihistamine available through an IV in most places is Benadryl. And then there's obviously going to be exceptions to that rule. So I don't want people to say that I never recommend it. But as a whole, when we look at the risks and benefits, it's really time for families to move on from Benadryl.
Yeah, and it sounds like there hasn't been any innovation or changes done to the ingredients of Benadryl since, you said, the 1940s, which feels like an awfully archaic medication to still have at home. So I love that you shared other options. What about the EpiPen? Should every household have an EpiPen? And what's the efficacy of an EpiPen? And when should, say, someone grab that versus something else?
Right. So EpiPen is the brand name for epinephrine autoinjector. So epinephrine is something that we actually make in our body, and it's used in medicine for emergent situations. So there's different concentrations of it. It's used in cases of cardiac arrest, but when it comes to a severe allergic reaction known as anaphylaxis, that is the first line therapy and should be the first and potentially second thing that you do if you're having a severe allergic reaction. The faster you use it, the more likely you're going to have a successful outcome. It's no different than the adage of time is brain when it comes to stroke. The faster you act, the less likely you're going to have significant consequences from that. So there's EpiPen, there's Alvi-Q, there's also now a nasal spray containing epinephrine called Neffy, which is a whole topic of itself. But the reason people should have it is if they have a history of anaphylaxis, or there's concerns that they could have it, like let's say you have a food allergy. You should always carry that with you. I don't give blanket recommendations of every household needing it because not everybody goes through anaphylaxis or has a food allergy. And also, unfortunately, epinephrine can be very expensive. Even though it's a life-saving medication, the way our healthcare system is structured, it can be unaffordable for many families to keep refilling them because an EpiPen only lasts about 12 to 18 months. So we have to be cognizant of who we are prescribing it for. And there's a lot of fear around needles, which is why it's exciting to have a nasal spray option now. But if you suspect you have something called anaphylaxis, where you are having trouble breathing after being exposed to an allergen, you are having profuse vomiting, diarrhea, and a rash that's multisystemic, you feel like you're going to pass out or a sense of impending doom, that's the medicine you go for.
You know, we talked briefly earlier about the environment. So I want to ask some more questions related to that, which is, does it make a difference whether kids are being raised in a city versus in the country versus the suburb in terms of how they react to environmental allergens and then also potentially food allergens? Like, sure, we get the same types of food worldwide almost, but the produce is different, how it's farmed, how it's cultivated. Talk to me about like where you live or where you were born and the impact that has on your, medical history as it relates to allergies.
Right. That's a wonderful question. So there is absolutely evidence to suggest that based on where you live will dictate your risk of developing various allergic diseases. Classic example, you live in an urban environment where there's air pollution, there's a lot of indoor allergen exposure, you've got a gas stove that emits, volatile organic compounds like nitrogen dioxide that can create airway inflammation. You could be living by a train track. You could be living by a plant, right? So all these different pollutants can increase the risk of developing diseases like asthma, as an example. The types of foods that you eat may be associated with developing food allergies. And we know that there's a community in Indiana, an Amish community, that has some of the lowest rates of allergic diseases in the world. And it's likely because at an early age, they're exposed to the traditional farming practices where there are, I call them friendly microbes. There's this old friends hypothesis where having early exposure to the right organisms, the friendly ones, are the ones that help downregulate the immune response so that you are more tolerant to your environment. That's not the same as saying, oh, get sick. There's this big misconception that getting sick builds your immune system, when in reality it actually makes it worse. So there are various viruses like SARS-CoV-2 that causes COVID-19. There's Epstein-Barr virus that causes mono, that are implicated in developing various diseases like multiple sclerosis, like lupus as an example. So getting an infection doesn't confer some type of resistance. It's more about the microbes you get. In fact, there was a study published recently that looked at children in Ireland who were born in the beginning of the pandemic when we were under lockdowns and comparing them to kids who were born not in lockdowns. And they found that the rate of food allergy was significantly lower in the kids that lived in a bubble, so to speak. So weren't getting exposed to infections. Therefore, they didn't have potentially the immune system dysfunction from fighting off that infection or needing antibiotics, which we talked about before as a potential risk factor. So I just want to impart on people that the idea that you need to get your kids sick to build up their immune system and get stronger, it's not how the immune system functions. It's not a muscle. It's more of like a library, if anything.
Interesting. I was reading a few weeks ago or a few months ago about blue zones around the world and how there are studies around longevity in certain countries, Japan, and there are a few European countries that are called blue zone because they live much longer, healthier lives into their 80s and even 90s. And so much of it, again, is, environment, diet. Of course, there's also other factors like relationships and community, which all create that. If there had to be like an allergy blue zone in the world, you mentioned Amish communities, which I think is super fascinating that I didn't even know about that. And I'm curious to hear, like, what is it about the Amish community in particular that we're seeing lower allergy rates compared to the rest of the population? And are there any such other pockets of communities in the world where the rates are lower?
Right. So everywhere in the world, there are allergies. It's just a fact of life. So it's a matter of which places have higher prevalence compared to others. So, this Amish community that I talk about, I mentioned earlier, they follow traditional farming practices. And so their exposure to animals and different microbes is quite different than if you grew up in the suburbs or in the city. You don't get that kind of exposure regularly, and especially early in life. And there are many other countries around the world, like in Africa and Asia, where they don't see nearly as high of a rate of allergic diseases. Keep in mind, though, that some of that may be a little bit underreported because they may not have the resources to diagnose these issues, because oftentimes people would say, yeah, I ate this food, I didn't really like it. And food refusal is actually a potential sign of food allergy. So children who it's not always just picky eating, but sometimes that could be a sign of a food allergy, and then they never touch it for years. And then it comes back and they try it and then they have a severe reaction. I've seen that from time to time where a child refused to eat cashews. They're like, I don't like this. And then they just never ate it, and they were able to go through life without reading labels, and they somehow were fine. And then they eat something that contains it and they develop a severe reaction. So there could be that kind of an issue. And there's not always, the greatest understanding of what it could be.
You recently authored a book all about allergies. I can see it behind you. Yeah. Tell me what sort of prompted you to write this book and why you were so sort of compelled at this phase in your career to put this book out. And also, like, what are the big topics that you're really trying to debunk through this book?
Yeah, this has been a project of mine for a few years now, and I'm really excited that it's coming out February 24th. All about allergies, everything you know about asthma, food allergies, hay fever, and more is a comprehensive overview of allergic diseases that started because there was an editor at one of the imprints of Penguin Random House who followed me on social media, who contacted me through one of my offices, and I had a lovely conversation with her, and she was explaining how her family was suffering from some various allergic type ailments, and there's really not a resource out there meant for the general public to go over all of these different topics that you and I are talking about in detail. And so she got me in touch with a literary agency in New York, who then helped me write a book proposal that then went to various publishers, and now I'm working through Plume, which is an imprint of Penguin Random House. They've been remarkable at helping me through this process. And so it's 18 chapters split into 3 parts. The first part is one that sets you up to understand the rest of the book. So if you are trying to learn something new, oftentimes you need to learn the language of it, right? And the language of anatomy and immunology, you have to have a baseline understanding in order to really appreciate the nuance and the complexity of the human body, and especially with regards to allergic diseases. So that bit of setup, once you get through that, then you get into the meat of the book in part 2, where we go through a lot of different disease states. allergic and non-allergic rhinitis, sinusitis, chronic hives and swelling, food allergy, drug allergies, even vaccine allergies, which is rare, but I talk about it and validate people's concerns about it. We talk about various mast cell disorders. There are folks who have diseases that are not completely understood that are often referred to as MCAS. That's what that is. And so I go through a lot of different diseases that are common, not so common, through narrative format. I tell stories of my patients or followers who I interviewed so that people can get a better understanding through a case-based discussion. And then the last part of the book goes into more details about different treatment strategies, from over-the-counter to prescription medications to immunotherapy, whether it's OIT or injections. And then a whole chapter dedicated to what kind of research we're looking into right now. And it's only a fraction of what we're actually doing, and it's exciting to see where we're going. And so you had also asked, what kinds of areas do I debunk in the book? There's a classic issue that's actually a significant public health concern, which is overuse of antibiotics. So a lot of times people think they have a sinus infection, and they look at the color of their snot and say, I have green snot, I must have a bacterial infection, I need antibiotics. And that's not actually what happens. So yes, if you have chronic sinus pain and pressure and you have congestion, and then you notice you're having some green mucus coming out of your nose, there's an infection there, no doubt, but it's more likely viral than bacterial in many cases. So that's an example. Another is talking about using local honey to treat allergies. And that's a myth that's designed to essentially, I love honey, don't get me wrong, but telling people that's going to treat allergies is not right. It's this concept of saying, well, there's pollen in the local honey that's in your area, so it's like getting allergy shots by eating it every day. The reality is that the pollen that you're allergic to is not the pollen found in honey, because pretty flowers that are insect pollinated, they don't release high amounts of pollen that are light enough in the air to travel, and then you come into contact with millions of pollen grains on a regular basis. So we are allergic to wind-pollinated plants like birch tree, Bermuda grass, and ragweed pollens, not to rose. If you sneeze when you're around roses, it's because of the fragrance, which is not the same type of mechanism.
So much of what you're saying is also so nuanced by someone's culture, right? Like I'm Indian by background. I was born in India. Of course, I left when I was 6 years old, but still, like, there are some traditional, old wives' tales, or they call it like homeopathic ways of treating this. And to your point, like, honey was such a big one growing up. Like, oh, just give her the local honey and it will strengthen her immune system and make her more resistant to all these like environmental and food allergens. So I love that you debunk that. And then just to kind of expand on that a little bit more, like, so then what is local honey good for? Because everyone's always recommending you eat the honey from the town that you are from or living in. So then what's the use of it?
Right. The location doesn't really matter to me. What matters to me is that if you have a child that's 12 months or older, right, if you give honey to someone under 12 months, they're at risk of botulism, which is a scary infection. Don't ever do that. But it's great for a natural cough suppressant and throat lozenge. It's really good at that. We know that. So when people think that their allergies get better, yeah, it might get better in the sense that your cough could get better, but it's not going to treat the congestion and the postnasal drip effectively. So anytime somebody's sick and they have a sore throat, yeah, absolutely go for it. I use honey all the time for that, but it's not meant to somehow magically make you stop itching and sneezing.
Are there any foods that help with that? Like, could there be natural food sources that aid in all of that, or no?
So the reality is that when people talk about nutrition and treating diseases, I think we need to move away from this concept of saying, oh, you need to eat garlic or you need to eat onions to fix this problem. That's not how it works. It's really the totality of your diet. All of it put together is what dictates your health outcomes potentially. So if you don't have fiber in your diet and throughout your life, you're at higher risk of having colon cancer as an example. It's really important to have a well-balanced diet to help maintain good health. It's the same thing that people ask me, can you boost your immune system? Is that from a dietary or supplemental standpoint, you really can't. And even if you do, from a conceptual standpoint, that would mean that we're increasing the risk of developing allergies or autoimmune disease, because the immune system, when it abnormally responds to foreign substances, that's an allergy. When it abnormally responds to your own body, that's autoimmune disease. You don't want your immune system jacked and ripped to somehow tear through these things. You want it to be healthy and balanced, not suppressed. Stress causes suppression. Lack of sleep causes suppression. A well-balanced diet helps balance it all out. You don't necessarily need supplements for everything. Vitamin D may be the only exception when we are in areas where there's very little sunlight and it's cloudy and it's cold. There could be some utility there, but I generally don't recommend supplements or a one particular food that's going to magically fix people's problems. It's really just the totality of everything. Do you exercise? Are you eating 3 square meals a day with plenty of fruits and vegetables that give you those micronutrients and the fiber and the proteins, all of that, not highly processed food? So that's the type of messaging I tell my patients.
Yeah, which is great. And I think there's also this like over reliance on vitamins and supplements, because the reality is most of them, if not almost all of them, don't have, enough of the dosage of the ingredients to really even move the needle. It almost sometimes feels like a placebo.
Well, also, too, don't forget, they're not regulated by the FDA, so you don't really know how much you're getting. There was a study published recently looking at melatonin as a sleep aid supplement, and the dosage they'd put in front of you on the bottle was vastly different than what was actually tested in many of the companies that were being tested. So that's a significant problem where you really don't know what you're getting when you take certain supplements, and some of them can really harm you. You could get liver damage, as an example. So it's not something that I think should be taken lightly.
Yeah, I agree with you. Okay, we're going to move on to a fun lightning round. So I would love to get your responses in a few words or a few short sentences.
Sure.
Most common food allergy, the first one.
Egg.
Most common environmental allergy.
In my area, I'd say dust mites.
What is the craziest food allergy you have seen in your career that perhaps like stopped you in your tracks or made your jaw drop?
Oh, wow. I've seen a lot. Let me tell you, I've seen some of the most unusual. One of the most challenging ones I'll tell you is that there are certain plants found in only certain Asian countries like India where families will bring in a particular plant that I have never seen before and expect me to try to figure out what's going on. And it's tough sometimes, but you could do something called a prick test where you prick the food and then you prick the skin with it. But it's real. I would say outside of that being unusual, I've had patients be allergic to bananas and get really sick. I had a patient once eat an entire banana in front of me and started violently vomiting and needing epinephrine. It was bad.
Wow. I love bananas. I would be so sad if I developed a banana allergy.
Yeah.
What is an allergy that perhaps you or someone in your family has had?
So there is a type of skin disease that is considered allergic. It's called dermographism. So that's where if you scratch your skin, it will create a hive directly where you put the pressure. So just a little bit of histamine is released. And so that's something that's actually very common. Many people don't even realize that it's technically a disease, because many people, they get the rash without itching. You don't have to do anything really about that. But if they itch all the time, and I see this, it can be difficult to manage. But that's something that I see quite often is in family members too.
What's the one question you want every parent to start asking an allergist or immunologist that they're not really asking today?
Well, I think this is true not just for allergists, but for healthcare in general, which I want people to ask, what are the risks and benefits of doing the test that you're going to do, and why are you doing it? What are the other alternatives? Basically getting at the idea of being an advocate for your health. When it comes to doctors who will test you for whatever it is, sometimes the tests are not helpful. And you really, if you want to understand what's going on with your body, you need to just ask. Say, hey, what do you think is going on? And if and then they should be able to tell you. I'll be honest with some of my patients and say, I really don't know what's going on here. I think we need another opinion from a different specialist. Or I don't know what's going on yet, but this is what we're going to do now to try to answer the questions to rule this in or this out. And so we need to have some patience with that. And coming from that level of humility, I think really will help repair some of the distrust that I see quite a bit lately, unfortunately.
What's the one thing you see parents stressing about the most in this space that you wish they wouldn't be so stressed out about because maybe it's not so important?
Well, I wouldn't say this is not important, but it still is important. Introducing foods to babies, I think it causes a lot of stress for families. In fact, I see on social media families parking outside of an emergency room to feed them peanut butter. And it's not to say that they can't do that, but the level of success may be less if you take a baby out of their known environment to expect them to try something new for the first time, right? Mm-hmm. And so the risk of having anaphylactic shock that's life-threatening is very low, especially for the first exposure. An allergic reaction to food usually takes 2, 3, or 300 times before you get an allergic reaction, because your immune system has to first see it to learn if it's good or not, and then make antibodies so that the second time you're exposed or the 20th time you're exposed, the reaction actually happens. So I just want to reassure families that if you listen to your pediatricians, they're going to help guide you in terms of when to introduce the foods, what to introduce, and how to do it.
So if you were designing a baby that's starting solids, if you were designing their diet, tabula rasa, like blank slate, what would you put on that sort of taste test, and in what intervals?
Right. So there's really no right or wrong way to do this, the order that you do it. I think people are moving away from saying you only do one food a week, something very slow like that. I mean, you can do a new food every couple of days. And the order of it, oftentimes we like doing the purees first with like fruits and vegetables. That's fine. But I would get those allergenic foods like egg, wheat, peanut butter, tree nut butter. Get those in as soon as you can.
I love that. And last question, if you were to, let's say if someone had a choice and if you were to pick city, country, suburb, where would you say is the best place for a parent to raise a child that was going to develop a really healthy immune system, everything else being equal?
Wow. That's a great question. I think if you consider healthcare, right? Because access to healthcare is important too, and the systems involved and everything like that. I feel like some of the Scandinavian countries are probably the best places to be. When you look at it from an all-encompassing standpoint, you've got universal healthcare, you've got crime rates that are relatively low, you have a socialized system so that yes, you pay higher taxes, but you have a lot more social safety nets with paid family leave, et cetera. And all of that is part of what we call the social determinants of health, which I think are taken for granted in a lot of the discourse that's happening right now. You can't say that everything is a moral failing of a person, right? And it's true of any allergic disease. It's not a person's individual fault that their child developed a food allergy. Regardless of genetics, there's other non-modifiable risk factors that we don't know of yet. And we also don't have a universal system where people have access to healthcare all the time or access to high quality foods, right? If you live in an impoverished area that has food deserts and you have a food allergy, it could be very unsafe. Most of the severe reactions that occur often occur in these communities because they just don't have the same level of access. And I see this borne out in my training and where I've worked previously. I've worked in various cities like St. Louis, Cleveland, Chicago, and now I'm in the suburbs, and it's vastly different how it's managed, unfortunately.
Yeah. That's amazing. I love that you actually referred to someone that has these allergies as a disability, because I think it really reframes how people think about this. Oftentimes, maybe you're at a dinner party with someone, it could be an adult or it could be with a group of kids who have certain food allergies. And I think a lot of people, the narrative in the media is like, this is so cumbersome. This is such a pain. You see memes of people saying like, I'm not going to date or marry someone that has food allergies because now all of a sudden, it's sort of the same joke that was running for a long time across social media about like, don't date a vegetarian or don't date someone who, is on a paleo diet. But I love that you reframe it like that because it's not their choice. Right.
It's not. So as a final message for folks to really take in who are listening, food allergy is a chronic disease. It's a disability. It's not a fad diet or something that somebody chooses to do. This could significantly impact not just their life, but the lives of those around them, families and communities. And when we really get a better understanding of the potential severity of it, I think we'll come from a better place of empathy. I call upon popular culture, media, TV, movies, all these different creators to really take a step back and think about, why is it that food allergies are the butt of a lot of jokes? It's because it's poorly understood. And because it's poorly understood and it's an inconvenience to people, it becomes a joke, especially because a lot of the times you don't see what actually happens. A lot of the symptoms are internal. It's something that if you live with food allergies, you have to think about every day, your meals, your social events, all of these different aspects of your life. You have to change in order to stay safe and healthy. And we really want everybody to be happy and healthy. And it's really not as difficult as it seems, but there are steps that have to be taken. And I think if people really have a better understanding of it, we'll just all be able to live a little bit easier.
I love that. Because it is such a privilege to be able to just, walk down a grocery aisle and just put anything you want in your basket without carefully looking at the fine print, right?
Right.
So I love that. Dr. Rubin, thank you so much for being on our show today. Where can people find you and where can people order your book when it comes out on Feb 24th?
Thank you. So my handle on most social media platforms is my last name, Rubin, R-U-B-I-N, then the underscore, and then Allergy. And so I'm on TikTok, Instagram, YouTube, Threads, Substack, Facebook, all the different platforms pretty much. You can also just search my name online because I'm all over the place. My book is going to be sold wherever you get your books, whether it's Amazon, Barnes & Noble, Powell's, Target, Walmart, etc. You just got to search for All About Allergies by Dr. Rubin, and you can pre-order or when it comes out in February 24th. Happy to hear your thoughts and can't wait for you to get a copy.
Amazing. We're going to link all of that in the description below. Thank you so much again. This was enlightening. It was interesting. It was fascinating. I so appreciate you coming on and sharing all your, all your intellectual knowledge about this topic with our audience today.
Thank you for having me.